Dr. Eberlein, you mentioned in treating breast cancer that the normal treatment would usually include surgery and then radiation, then chemotherapy. And you also said that your estimates would be that 4 out of 5 patients wouldn't need both radiation and chemotherapy. How do you determine what are you doing to try to help determine which 4 patients don't have to, one, pay for it, but maybe more importantly go through the personal effort of having a treatment that they don't need? How do we know which ones would need it, or how do you hope we figure out which patients need it and which patients don't?
So we're using molecular markers and genomic analysis of tumors. We've now identified approximately 98.6% of mutations associated with human malignancy. So we know what those are. And now the question is, can we develop a relational database combining genomic information with clinical information to be able to recommend to an individual patient what her treatment should or should not be? The greatest opportunity is probably in areas like early breast cancer, premenopausal breast cancer that I cited, where we may be able to solve this dilemma and identify the 80% who don't require further toxic therapies from the 20% who do. And we're now applying that kind of information in clinical trials through genomics and molecular markers from individual tumors of a particular patient. The same is true, by the way, in colorectal cancer, stage 2 colorectal cancer, where 25% of those patients after surgery will have a recurrence. So these are dilemmas that we face across many of the tumor types of cancer, but the solution is going to be a similar type of solution.
And 98.6% of mutations being determined, that you can determine enough, or do you need to have understood 100% of mutations, or what's the range here where you would recommend to a patient in that foreseeable future that you really may not need this, but it's possible, so you should have chemo, or we think there's almost no likelihood that chemo is necessary in this case? Having
98%, sir, is a wonderful start. Obviously, we're looking for the remaining 1.4% of driver mutations. That said, clearly we have developed relational databases based on the 98.6% that we do know, and are applying those in breast cancer and lung cancer and other leukemias and other types of cancer.
Thank you. Dr. Grabowski, in your work and your testimony, I think you mentioned that if we could delay onset of Alzheimer's by an average of 5 years, that would reduce the future patient cost or the future patient population, or both. Would you talk about that a little bit?
The incidence of Alzheimer's disease, dementia, doubles every 5 years after age 65. So if you could delay onset by 5 years, you would cut the number of cases in half. And by inference, you could cut costs in half that are related to Alzheimer's dementia.
Have you looked at the NIH projections on taxpayer cost of Alzheimer's?
Yes.
And what are they? What are those by, say, 2050? I think that was the outside number.
So the number of cases that we have on our hands by 2050 will probably about triple. So we're talking trillions of dollars of direct and opportunity costs related to Alzheimer's dementia.
I think there's a $1.1 trillion number out there of today's dollars, which would be twice the defense budget, would be the taxpayer money that would be spent on Alzheimer's. And we deal with these big numbers like $1.1 trillion, and how much more is that than $1.1 billion hard to get a real sense of that until you think twice the defense budget if your work and other work doesn't get us to a better place, not to mention the individual and family impact of what we see here.